All right. So thank you all so much for joining us this afternoon. My name is Samantha, and I'm a licensed psychologist and the assistant clinical director here at Austin Anxiety and OCD Specialists. And today we'll be serving as the moderator for this event. So we are delighted to have Dr. Elizabeth McIngvale joining us today. She is the director of the OCD Institute Texas in Houston, and also now the co-host of the podcast Anxiety Society. She founded the Peace of Mind Foundation as well as OCDchallenge.org and is also serving on the board of directors at the IOCDF, which is the International OCD Foundation. And today, through the support of IOCDF, she's here to share about her journey with OCD and how to best support a loved one with OCD. So a collective welcome from everyone to you, Dr. McIngvale. All right. Well, I'll get us started with kind of a first broad question, if that's okay with you.
Sure.
So would you mind starting by telling us a bit about your journey with OCD and kind of how you've ended up where you are today?
Absolutely. Yeah. Thank you so much for having me. I'm excited to be here, and we will leave plenty of time for Q&A at the end. I'm an open book, so feel free to ask any questions. So you can jot those down. You can put them in the chat now, whatever you feel best doing. Yeah. So my journey with OCD has been long and interesting, and is really something that I feel like has taken quite a drastic shift in the past 5 or 10 years compared to the first 20. And so I want to talk a little bit about that. So I was originally diagnosed right around the age of 12. I started experiencing lots of different OCD symptoms. So my OCD really focused primarily on a lot of scrupulosity, a lot of fear of harm, kind of all of those sort of things. And it presented in different ways. So it looked like contamination, but actually the contamination wasn't really these fears of germs or fears of me getting sick. It was more hyper responsibility. Like, if I get contaminated and get a disease, what if I give it to someone else and cause harm to them? And how could I tolerate that feeling? And then scrupulosity and other subtypes. I live here in Houston, Texas, where biggest medical center in the world is right here in our city. However, at the time when I was first diagnosed, there really wasn't effective treatment. It took my parents probably about 2 to 3 years to really try to figure out what was going on. I was hiding a lot of my symptoms, as most of you know and can imagine. Most people with mental health conditions, there's a ton of stigma, there's a ton of shame. And so we hide what we're going through. We don't talk a lot about it. I felt like, well, if I talk about it, who's going to help me? What are they going to think? What are they going to do? No one talked about mental health, especially back then, right? You had like Dare to Kick Drugs Out of America and these different programs where you would end up talking a lot about substances or different behaviors, but nobody talked about what led to those behaviors, like what some of these underlying conditions could be. And so I think what made it really hard and typically makes it hard for individuals with OCD is that these thoughts are irrational, right? Like, they don't make sense, that they're irrational, and yet you feel like you don't have control over them anyways. And so there's this piece where you feel it's like even harder because you have insight that I always kind of said when I was young, I was like, I wish I thought these were rational or had thought I was in my own world, because it wouldn't feel as exhausting to do these rituals, right? But the reality is that you hate doing the rituals, you hate the time they take up, but you feel like you have to do them, like you don't have a choice. And so slowly but surely, unfortunately, because I wasn't getting good treatment, my OCD just continued to worsen. And I talk a lot about how it was kind of like overnight. I went from functioning to not functional. A lot of people think I mean literally overnight, and I don't mean that. It was probably the span of 6 months to a year where OCD symptoms just continued to pile up and continued to get worse because they really weren't treated. And unfortunately, what does that lead to? Untreated OCD leads to worse OCD and worse symptomology, to the point where by the time I was 15, I was totally disabled by my illness. I was taking 6 to 8 hour showers. My parents were having to pull me out of the shower. I was doing everything in multiples of 42 because that was my mom's age at the time, even though because of my scrupulosity, I thought that was a bad number because 4 + 2 was 6. And so I did everything 42 times. I sat up from bed in the morning 42 times, turned my body 42 times, moved my right leg 42 times to be able to stand up. And I would get to the bathroom. I would turn the sink faucet on 42 times, rinse my hands off 42 times, get 42 pumps of soap, rinse my hands back off 42 times, turn the faucet off 42 times. And then my OCD would say that was one set. You should do 42 sets of 42. And so every activity, every daily task became unbearable, right? And I did what most people with OCD do, which is then I started to avoid. I started to avoid showering and brushing my teeth, like doing activities of daily living because they felt so daunting and exhausting. And so over time, as I continued to get worse, my parents, I also started to have a lot of thoughts of self-harm and depression at this time. And my parents, of course, knew that they needed to figure out a better and or more significant intervention because outpatient wasn't working. I had been going to outpatient providers in town. We actually did end up finding one provider who understood OCD, but she was very honest, which we appreciated, in saying, like, I've never seen a case this severe. I really don't know how to help your kid. Like this, I'm not the right fit. Like I've really only done kind of mild to moderate OCD on an outpatient level. And so eventually my parents found the McIngvale Clinic, which had an inpatient unit for OCD at the time, and it was in Topeka, Kansas. This is when I was 15, and I went there. I went there for about 90 days. I was there at a time in my life where, there was so much shame and guilt around having this illness and suffering at the severity level that I did, that I was dealing with a lot of things at once. I was a teenager in an inpatient unit, right? Like all these things. And at the same time, for the first time in my entire life, I met other people who had OCD and who understood what it was like. And there was this relief in that, in knowing that, like, yes, I'm in this facility, but two things are happening. I was, for the first time, with providers who actually knew how to help me. They didn't seem afraid of my illness, afraid of my symptoms, unsure what to do. They were actually really confident in the fact that they could treat me, they could get me better, that they had seen cases like mine. And then I also met people who had similar struggles. No one's OCD, of course, is the exact same, but being able to meet other individuals who were also struggling and had a similar diagnosis just really helps you understand you're not alone, right? And kind of gives you that group camaraderie that a lot of us need when we're going through hard times. And so I spent about 90 days there. And at the end of that treatment stay, I was going back home a pretty normal kid, right? In my mind of normal, like I still had OCD, I was still struggling, but I could take 15-minute showers. I could wear whatever clothes I wanted out of my closet. I could go back to school, sit in different family cars, like sit in all the areas of my house. I could do all these things that OCD had taken away. And I feel like I had so much gratitude for it. The problem is that I didn't have an outpatient provider lined up. And I was like so excited about this new freedom that I had gotten, this new functioning level, right? Like I had been so dysfunctional because of my illness, and I was back to a place where I could be functional again. I could do these things I hadn't done in forever. That I also naively, I think, thought like, oh, treatment's done, right? I can go back and be functional. This is great. And it just slowly crept back. And so by the time I was 15, I had relapsed and I went back to the same inpatient facility at the time. McIngvale had now moved to Houston. So it was where I live in my backyard. And treatment honestly wasn't as successful the second time around. It was the same treatment, it was the same provider. But my willingness to engage in treatment had totally shifted. I was in this kind of rut of feeling like I'm always going to have this illness. I'm always going to struggle. Why should I do the therapy? Why should I do the work? Like, what is the value and use in it? And I did make the choice to go to treatment on my own this time around. And so I went to treatment, and certainly, like, there was some success in the outcomes of treatment. But overall, it wasn't that same level of like suffering to freedom, because I was in this like non-acceptance mind frame. I was really stuck looking in the rearview mirror, spending a lot of time asking why. Like, why do I have OCD? Why do I have to deal with this? Why me? Instead of being at a place where I could accept that this is my journey. This sucks. Like, yes, you don't have to accept it with like gratitude, right? No one's thankful for having OCD, but you do have to be able to say, like, these are the cards I was dealt and how am I going to move forward? Unfortunately, guys, I was diagnosed and treated for OCD. I mean, that first time was, well over 20 years ago now. And the way we understood both OCD treatment and OCD as a whole is this understanding that it was a chronic illness, that you would always have OCD, that you would always suffer, and that if you could become functional, that was amazing. Like that was great, right? And so for me, I think being able to go back to school while I was struggling felt like that was successful treatment, right? And going to college, even though I was still really struggling, functioning was what I really fought for because it's what I understood to be successful treatment or recovery for OCD back then. I really thought that recovery meant like I could function again, even though I was struggling. And I really also thought that ERP was a treatment you had to do forever. I thought that ERP was something that every week I would need to be going to ERP. I'd need to be actively engaging in it, sometimes twice a week, sometimes less, sometimes more, but like that it was something that I would always have to do to manage my symptoms because I have this chronic illness that I would always live with. And I'll kind of answer in this question here because I'm making it very long, but I think that for me, that is like if I could tell my younger self something I know now, I wish somebody would have told me that wasn't true. That OCD doesn't have to be a chronic illness, that ERP, if done appropriately, can actually get you freedom from this illness. And you can actually be at a place where you won't even meet diagnostic criteria and where you don't have to do ERP every day as this chore, but instead you're living your life every day. And OCD is in the background, if not really there. Because I didn't believe that because that wasn't how I understood both the diagnosis of OCD and or treatment.
Before I jump into the next question, I just want to voice appreciation for you sharing that. And I think that's why I think it's so cool, I guess is a basic word to use, to hear from people in your shoes, because you have, now this professional experience, we call it, right, of being, a leader in the OCD field and providing treatment to other people, but you have a very rich lived experience with OCD. And I think that just provides such a unique lens into what the experience of OCD is like, not just at the time of diagnosis and treatment, but also after, like what does recovery look like? And so like you mentioned, right, it's not that you have to, okay, I'm every week in ERP and I'm just managing, right, and I'm just kind of like getting along or getting by rather than really living. I am curious, do you find yourself like at this point in your recovery, like leaning into still any kind of concepts or like tools or anything more as just kind of like life skills now versus treatment tools like they might have originally been introduced to you as?
Totally, so I mean, ERP as a whole is something I still engage in every day of my life, but it's not this active task, right? So it's not like I'm having to sit down in the morning and get my notebook and say like, okay, what am I struggling with today? What are the ways I'm going to do ERP? In fact, I tell people and I tell clinicians all the time, if you're seeing a patient and every week you are dealing with the crisis of the week, right? And you're having to reset up and engage with ERP for that crisis, you're not doing ERP correctly, right? You're doing ERP to treat the symptoms versus actually doing ERP to address your core fears. And I did that for most of my life, right? Like I did ERP to minimize symptoms so that I could increase functionality versus actually doing ERP to get to the core fears that even caused these symptoms to be triggering, that caused these thoughts to stick, that caused them to continue to give me distress. And so, I think to this day, yes, I know I have a brain that can get a little bit stickier, right? And so I know if an intrusive thought pops up, that is a little bit stickier in that moment, am I going to choose to avoid it? Am I going to choose to ritualize for it in which it will be louder? Or am I going to make that conscious choice to approach it, right? To not let fear or anxiety dictate my life, my decisions, the way I respond, act, all of the above. And that's not really a conscious choice. It happens automatically now, so I don't have to usually like sit down and weigh it out and think about it. It's like a 2-second decision that it's just automatic of like, oh, like, yeah, there's a piece of me that doesn't want to do this right now. More the reason why I'm going to go do it, right? And that happens, by the way, for all of y'all on this call, whether you have OCD or not, is like there's many things in our life, right? Our alarm clock goes off in the morning or we have a commitment. Like most of us don't want to get up, but we get up and do it anyways. And as you get up and get ready, you kind of forget that you don't want to get up, right? You're moving forward with your day and you've at that point made the commitment that you're getting up. And so this is a conscious effort that people make all the time. Like you don't feel great about something, but you still choose to do what you know is important anyway.
I think that's really great. And as you're talking, like I find myself thinking of like it's like an empowered stance that you get to start taking with your life of kind of shifting, I think, like a lot of us talk about with our clients, from the, oh, I have to do these things, to this is what I want to do with my life. And it sounds like, the choice in that is such a big part for people to be able to learn that, like, you do get to build up strength to know that you can make a different choice in those situations.
Exactly. And that you can always make a different choice.
Very cool. Okay. Well, I might shift us a little bit. You were mentioning earlier, that when you first went to the residential or inpatient treatment facility, it was kind of your first time being around other people who were having similar struggles with OCD. And so I was curious if you could speak to, the importance of that, of finding community, if that's something someone wants and thinks could be helpful for their recovery, and also how to go about doing that.
Yeah, so there are so many ways you can do it nowadays, which is so awesome, right? But you can definitely join the International OCD Foundation, and IOCDF has incredible ways that people can connect and build a community, whether it's your family member or an individual. They have online conferences, in-person conferences, support groups, right? There's all sorts of avenues that are really, really important to do. With that being said, I will also say that it is really important to build a healthy support network. Just because you meet other individuals with OCD, if they're all really in their struggle and the message is kind of negative, and the message isn't this message of like treatment works and I can get better, and you're not motivating each other and keeping each other accountable in recovery and seeing each other do that, but instead it's like a commiserating sort of, that can be useful to a degree, but if it gets to a point that it interferes with treatment, right, it's kind of like we're all just like talking about how much we're always going to suffer and we're always going to struggle and always going to have OCD. That can also be unhelpful. So I want us to think about, how do we build our own healthy communities, and what does that look like? For me, I started advocating when I was 17 years old. So I've been doing advocacy now for 20 plus years, and it's something that has really changed my life, because it allowed me to take this struggle, challenge, this like horrible thing, and turn it into something useful. It doesn't mean I'm grateful that I have OCD or that I love that I have this illness. However, I talk about the fact that it really put a lot of purpose to my pain, right? It allowed me to say, okay, yes, I have OCD. Yes, I struggled a lot. It really impacted different times in my life, and something good can come out of it, right? I can help other people. I can use my story to help destigmatize mental health, OCD, all those things. And I really talk a lot about how I do think that advocacy is one of the final legs of treatment, right? When you think about even like a addiction recovery model, if you look at, 12 steps program, you go through the 12 steps, and then what happens, like you become a sponsor and you help someone else and you help sponsor them. And part of that is for them, but part of it is also for you, right? It keeps you in recovery when you're pushing someone else and sponsoring them, and keeps you accountable. And it also allows you to have some purpose and meaning to this really difficult thing that I think is really an important perspective shift for us to have. So I think that community is critical. I think you have to build it, but I do think you should be thoughtful about making sure you're building a healthy community that's encouraging you to take the right steps in treatment and recovery, and not a community that can keep you stuck.
Yeah, I think that's a really important distinction, like you're mentioning, just so you know it's going to be supportive for you rather than potentially detrimental.
Exactly.
Okay. So I might shift us toward kind of the supporters and loved ones and caregivers side of things, which I'm imagining you've had a lot of perspective on, both from your experience of going through treatment for OCD and working on that with your own family, and now as a provider, an advocate and leader in the field, trying to teach other families about that. And so I was wondering if you could speak to a little bit of what you would recommend, family members do to try and be the most compassionate, caring, helpful supporters they can be to their loved ones or friends or family or whoever might be struggling.
Yeah, so first I'm gonna get my favorite family book by Ellie Leibovitz. So if you have not already read or purchased this book, I think the best thing you can do is, yes, it says childhood, don't worry about it. Read this book called Breaking Free of Child Anxiety and OCD by Ellie Leibovitz. I think Ellie does such an amazing job of helping us understand that the way we parent, but also all of the little things that we often do that actually encourages unintentionally this anxiety, OCD model, but also that fragilizes our loved ones, right? So are we sending the message that you can't tolerate anxiety. I need to protect you from this. I can't trigger you. I can't make you feel distress, in which case we're really fragilizing you. We're sending that message that you can't do hard things. You can't tolerate this anxiety. And I think that as a loved one, it is really important, first and foremost, for us to just think about what are the messages we're sending. And when you think about parenthood, for a lot of you on here that are parents, this happens early on, right? My toddler, I have a 2 and a 3-year-old. My 3-year-old Olivia started to exhibit some pretty significant signs of OCD and anxiety last year. And they really all started around bedtime. And it was a lot of bedtime anxiety, made things a lot worse, right? Which is normal. That's a normal thing. But some specific, like, irrational kind of thoughts and fears around who's going to wake me up in the morning, what's that going to look like, oh, that book might be out of place, you have to put it back in the right place before I'll be able to fall asleep, like my tiger needs to be perfect, like all these things. And as a parent, your natural go-to is to comfort your child, right? Like that's like emotionally normative. Like it is normal to love them, to support them, to answer their questions, to reassure them, to hug them, right? To give them this comfort. At the same time, as a parent, you know pretty quickly when I'm actually providing comfort and support versus I'm actually just responding to anxiety, right? And so some quick examples of that, even in toddlers, are things like my daughter saying, "Who's going to wake me up in the morning?" and me saying, like, "Olivia, mom, I'm going to wake you up. You know that." And then asking it again and again and again. And at the 20th time, she's not actually asking the question. She knows who's going to wake her up in the morning. Yet at the same time, her anxiety wants her to keep asking. And so the work doesn't fall on the kid, the work falls on the parent, right? You've also probably maybe at some point sleep trained your kids, not necessarily everybody does that, but if you did, it's hard. Like it isn't fun to walk away when your child's upset and anxious, right? But at the same time, if we draw hard lines and we're consistent and we have a schedule and boundaries, after about 3 days, typically, they will understand how it works and they move on and they're fine. But if one day I do it, the next day I don't, the next 2 days I do, the next day my husband doesn't, right? And we're inconsistent, that anxiety continues to be there and real change doesn't happen. You have to be consistent and scheduled with your kids and loved ones. So the first piece is us really thinking about both the active messages, but also the subtle messages that we send to our kids that is the opposite message of what we want, right? Are we sending messages that anxiety is dangerous, that you shouldn't feel it, that when it's there, I'm going to get rid of it? Or are we sending the message that you can't tolerate anxiety? And so I need to not have the same conversations with you I would with my other kids, or, do the same behaviors because I don't want to trigger you. And so we have to think about that. The second piece is to remember it's very different if I'm talking to parents of a child with OCD versus parents of an adult child with OCD, right? Because as a child, you can technically take your kids to therapy. You can engage in therapy. You can set stricter boundaries, right? They're a minor. Once they're an adult, they have to want treatment. And I will tell you, as somebody who now runs one of the 3/4 residential programs in the world for OCD, so we treat the most severe OCD. When a patient comes to our program because the parents are pushing them to come here, the outcomes are never good, right? And we tell the parents that, and we tell the kid that like, if you don't want to be here, you shouldn't stay here, because you're going to do this, like you're going to do some of it, not really, you're not going to be committed, but you're here because your family wants you to be. But then worse things happen. You start to think treatment doesn't work for you. You can't get better. ERP can't help you, when really it's just that you weren't willing to do ERP or you weren't motivated to do it. And so for a parent, it's us understanding what are the ways we feed in unintentionally to OCD and create these patterns of like learned helplessness within our loved ones, right? Where they start to learn and believe that they are kind of helpless and that family members have to do these things for them. But then also, what are the boundaries we can set to help them be willing to get treatment?
No, I agree with everything you said, and I will cheerlead the heck out of that book as well too. I think it's wonderful, and I completely agree. Like it's for everybody across the lifespan, like any family member. And I think of I was in a training once that Dr. Regine Galanti was giving, and I remember her words will always stick with me, that parenting OCD is not intuitive parenting, right? Like a kid with OCD, a kid with anxiety, they don't send you home from the hospital and are like, hey, if this happens, here's the guidebook. Like we don't know what to do. And I think OCD loves to take advantage of so many intuitive parenting skills, and it likes to get families to co-compulse. And I love everything outlined in that book to kind of help prove that and help you lean into your value as a parent or caregiver in the way you want versus the way OCD might be taken advantage of.
Exactly.
So if we think outside of maybe the central supportive unit for someone, I think of a question that I get from families at, across the lifespan as well is, how do we share about this with everybody else in the family, right? Like, because I think there is sometimes that urge to kind of secret keep or hide these things from other family members for understandable fear of stigma or judgment, for not having the words to try and figure out how to explain this to whether it's, extended family, neighbors, teachers, whoever. So I'm curious if you have any thoughts on that at all.
Yeah. I think that I always talk about disclosure as being something that should be thoughtful and something that we should do slowly. Like, I don't think if your child's struggling, you should go publicize it on the World Wide Web without talking to them about it. Or I think you need to be thoughtful about that, and it should happen slowly. I want you to start with the people who really need to know, right? Like talking to their educators, talking to their loved ones, right? Their grandparents, people who kind of might wonder what's going on, but also people who need to learn what ways to be supportive and not enable, right? Because you don't want, for example, in my household, we have a nanny who helps take care of our kids all the time because my husband and I work. And if she's not on board and doesn't understand the way to respond to my daughter Olivia's anxiety, which by the way is like almost gone now because we didn't reinforce it, she would undo what we did, right? So she definitely needs to know. Like, there's some folks that you need to start with that. What I will say though is that I find across the board, people are so much more receptive than people think they're going to be, right? It is very rare that I hear people saying that went as bad as I thought, or, right, it's typically, oh, it went a lot better than I thought, or, oh, wow, they were actually really supportive, or, it was really nice because they have a family member struggling with anxiety and they asked me for some education or some tools or some, resources or support that I've learned. But what I also say is there's a right and wrong way to go about it. What I typically want to do is start with education, guide people to great websites, great resources, great brochures, great texts, great books to learn. And then once they start asking questions is when we can disclose a lot more, right? Because they're at a place now where they're curious, they want to learn more, they have an open mind. And a lot of it is about our approach, right? If our family member is triggering our kid and we're going to them saying they have OCD, don't trigger them, they're not going to be receptive. They're going to be feeling shame. They're going to, like, all these things are happening at the same time versus if we're able to talk to them about it slowly. I also don't want you to tell family members to act differently around your loved one, because again, that's fragilizing them. That's sending the message that they can't tolerate anxiety and starts that whole pattern of enabling.
I love the theme of messaging here too, of, what are the message we're sending? What are the subtle ones, the direct ones? What's the message that somebody else could receive? And I think it's so important because a big theme of treatment too is helping the person who's going through treatment try to start sending new messages to their brain as well. And so we want to make sure that all the messaging is consistent, right? That we're trying to build strength and empowerment and not, like you're saying, like fragility or, incapability or something like
that. Yeah, 100%.
Yeah. Okay. So I know you shared a bit of a kind of a message of hope, I think, at the beginning of our conversation today around, what recovery really can look like, right? It doesn't have to just look like this management of symptoms. And so I'm curious what maybe a message of support or hope might be for someone who is either really stuck in treatment. Maybe they're kind of at one of those plateaus of like, okay, I've kind of leveled up, but I'm feeling really stuck again. And I don't know how to advance to the next level. Or maybe even for folks on the call who are parents or caregivers and are noticing that with their own kiddo in treatment.
Yeah, I want to know what's going on, right? So I really want us to think about, like, why are we getting stuck? What's happening that's causing us to plateau, and to dive into that. And if it typically there's two reasons. We're either holding on, right? So we're either like we're at a place where we're doing ERP, but we're still holding on to either safety behaviors or some sort of, fears, right? But we're not doing it all the way. Or we're kind of white knuckling our way through, right? We're like doing exposures, but we're not really committing to them. We're not really letting go. We're still doing them with hesitation, with anxiety, instead of doing them in a way that we're going to be able to learn new things. Everybody who's doing effective OCD treatment, if it's effective for you, it should get you to a place of freedom, not to a place of functioning. However, here's what I think. This is my own theory. There's not research behind this. I think most people use treatment to get about 70% better. And when you go from 0 to 70%, that's miraculous, right? You're like, I can do things I wasn't doing. Like, this is amazing. I have so much of my life back. Yeah, like I still have 30% of my OCD, but like that's nothing compared to what I have, right? And so it feels really great. Treatment really worked for you. And most of us would say if someone gets 70% better, like that was a pretty good treatment, right? That's pretty successful for most things in life. Problem with that is it can be a problem or it can be great. It's a problem if we accept that the 30% is always going to be there and that is kind of like our burden to bear and like what we're always going to struggle with because we're holding on. So that means we haven't done all the work. There's quite a bit that we're still holding on to, but also 30% doesn't stay 30%. Right? OCD grows. You wouldn't, if you had cancer, you wouldn't go to your oncologist and say, just get as much as you can. If you get 70%, I'm going to be thrilled. You're going to say, no, I want you to get all of it. I want to know it's gone. I want to be in full remission. OCD metastasizes. It will grow. It doesn't just stay at that level. The great part, if you do 70%, and what I love to see is like a lot of patients will get to 70% and they still have that 30%. But they may be a little bit unwilling to do that final remaining work, right? They're kind of plateaued. And so what I tell them is, okay, like, I want you to go live your life now. I want you to re-engage in school and work with your family, with your friends. I want you to start dating. I want you to start doing all these things that you couldn't do because your OCD was at 100% that now you can do even when it's at 30%. And the goal with that is that when they start doing these values-based activities and life starts to get loud and bigger than OCD, they're going to want to do that last 30%. Now they're going to be so much more motivated to do it because it's not going to feel like, oh, no big deal, I only have 30%. It's going to feel like, oh, I hate this remaining 30% because it's stopping me from doing these other things I want to do. So we have to get you building a life, engaging in values-based activities, like doing those awesome, exciting, driven activities. And I think that can help get you over the hump as well. But just kind of pushing someone and telling them and like trying to talk it into them when they're plateauing typically isn't going to work.
Yeah, we have to make sure they're at a place where they can hear that and they can see that themselves. Yeah. So this next question is kind of twofold, and I'm going to ask one last question before I can stop hogging the mic and turn it over to everyone else. But I would love to hear, on the one hand, what has been most exciting for you about where the OCD field and treatment of OCD has gotten to at this point and, where it's going. And also, how can families stay up to date on that? Like, how can they follow and ensure that they're staying up to date on learning, about the advancements in the treatment of OCD so that they can continue to best support their loved one?
Yeah, I mean, my biggest feedback would be like, you're not a clinician or a researcher, you're the parent in this situation. And so I hope that you have a good clinician you can trust that they're doing that. If you're working with a clinician who follows evidence-based treatment and who understands research and protocols. So what I want you to think about is like, where did they get their background and training? Was it specialized? Is it OCD and anxiety specific? And then do they continue engagement? So are they, attending different trainings? Are they, going to the IOCDF every year? Like, that's really how they're going to stay up to date, and they should be sharing those advances. The reality is that ERP is still the most effective treatment. It's been the most effective treatment since the 1980s. It's still the most effective treatment for OCD to date. Does ERP look different? Yeah, of course it does. Like, the way I do ERP with our patients is very different than the ERP I received 20 some years ago. That doesn't mean that the ERP I received didn't work. It's just that we've learned a lot, right? We have an inhibitory learning model now. We don't focus as much on SUDS and anxiety levels. We, really should be doing social justice and values-based ERP, right? We're doing less of a habituation model. Like, there's some shifts in it, but the treatment itself hasn't really changed that much. What I would recommend, though, is if you don't already go to IOCDF frequently, is go to iocdf.org. And this is really our international organization that really, oversees a lot of OCD work, and that you can feel good about the fact that it's vetted, it's evidence-based. And they have clinical recommendations, and they have a scientific advisory board who are constantly updating what are the most up-to-date clinical recommendations for OCD, both medically, so medications like psychiatric wise, and then also behaviorally. And it lays out which ones have the most evidence, and that is a good place that you could go to if you wanted to learn more about a new intervention you heard about, or something that you read about that you want to see, okay, is that being actually acknowledged like globally and on a different platform as a new evidence-based treatment for OCD?
Awesome. Thank you so much. Before I turn the recording off, do you have any last messages of support or hope that you would want other people to hear who aren't on the call today?
Yeah, I think the biggest thing is just to remember that we really should be fighting for freedom, not functioning. And if we accept functioning as the best we're ever going to get, we are holding on to OCD. And when we hold on to OCD, it sets us back, it limits our life, and it also increases the chance that OCD will grow and continue to play a significant role. I did a webinar this morning on IOCDF with Kim Quinlan and Chris Tronson, and I loved a couple of Kim's statements. And one thing she said is, I want to get to a place in my life where there's not any emotion that I'm unwilling to feel. And I thought this was such a great example of just even OCD and anxiety treatment, but like, are we walking through the world hoping that we don't get triggered, that we don't get scared, that we don't have to face our fears, in which case our fears will own us. They will define how we act, how we live, everything we do. Or are we walking through the world with what I like to call a bring it on attitude? Are you at a place where you have no fear around anything your OCD throws at you, because you know and have confidence that you can handle that and that you'd be able to walk through that and navigate that? The other piece is the question I get all the time is, how do I get motivated to do treatment? Like, how do I motivate myself? How do I encourage someone to be motivated or be willing? No one likes this answer. Motivation doesn't come first. Behavior change comes first. Do not expect that you're going to feel up for doing ERP before you do ERP. You're going to feel up for doing ERP after you've done ERP and you see what it can do for you, right? You have to do the things to feel motivation. You don't feel motivation and then do it, right? Think about how many things in our life, like I have two toddlers, a 2 and a 3-year-old at home. Like, I don't want to wake up. Sometimes I want to sleep in. Sometimes I don't want to get up, right? When I hear them in the morning, or I need to get up, or I need to get them ready for school, or lunch is packed. I don't really want to do those things. I'd much rather do a lot of other stuff. And I'm not going to feel accomplished or ready to go until I get up and do them, right? I'm not going to be like, oh, I'm just going to sit here till I feel ready to do those things. Like, no, I'm probably never going to feel ready to make my bed or feel ready to, not hit snooze on my alarm clock. But when I behaviorally respond differently, I make my bed, I don't hit snooze, I get up anyways, and I start doing these activities, then I get to start feeling the benefits of them. Right. And so motivation doesn't come first. Behavior change comes first. Motivation comes after. And so we have to remember that like you have to, think about it. Think about in your life how many times you felt down and out and you were going through a tough season and a friend or a family member said, let's go to dinner. And you really didn't want to go. You didn't feel up for it, but you went anyways because they asked you to. And afterwards you got home and you thought, oh, like, actually kind of enjoyed myself. Or maybe you even send them a text. It's like, thanks for making me go. That was really good for me. I'm really happy I went, or that I got out of the house, right? You didn't feel that way first. You actually felt ambivalent. Maybe you didn't even want to go. You felt that way after. And so remember, motivation happens second, behavior change first.
Thank you so much for that. That was great. It's also making me think about, like, I think willingness might be the most frequently used word in my vocabulary as an OCD and anxiety therapist.
Yes.
It's like
and what does it mean? How do you create it? What does it look like? All those things, right?
Exactly. All right. Well, I'm going to turn the recording off, everyone, so that we can take some questions from y'all in these last 20 minutes. So